Most ovarian tumors arise from the surface epithelium of the ovary, known as epithelial ovarian tumors. Some tumors arise from the germ cells inside the ovary. They are called germ cell tumors. Less commonly, ovarian tumors may arise from the cells surrounding the germ cells or other stromal cells. Their name is sex-cord stromal tumors. During normal pregnancy, when a germ cell is fertilized by a sperm, they will produce a zygote formed of one cell. This cell will divide and multiply, forming a large number of cells. Few days later, a part of these cells will arrange themselves into three layers, known as ectoderm, endoderm, and mesoderm. These layers will form all human tissues. For example, ectoderm will form skin epidermis, hair, and nervous system. Mesoderm will form bone, muscle, cartilage, and connective tissue, while endoderm will form stomach, intestine, colon, liver, pancreas, and the bladder. Ovarian dermoid cyst is a germ cell tumor that arises from a single germ cell. It is the most common ovarian tumor in women in second and third decade of life, forming a multicystic lesion which may contain any form of human tissue, such as bone, hair, or skin, because the germ cell is the origin of all human tissues. All these are mixed in a sebaceous material, which is thick, sticky, and often foul-smelling. Ovarian dermoid cyst is almost always a benign tumor. However, malignant changes may happen in 0.2 to 2% of cases. Risk factors for malignant changes include age over 45, tumor size more than 10 centimeters, rapid growth, and the presence of low resistance flow inside the cyst during Doppler study. Most cases of dermoid cyst are asymptomatic. Some women may present with a mass or pressure symptoms, and less commonly it may present with acute abdomen due to cyst torsion or rupture. The definitive diagnosis of ovarian dermoid cyst requires histopathologic examination. However, it has a characteristic ultrasound features. These include dermoid plug, dermoid mesh, and the floating fat globules. Dermoid plug is a hyperechogenic nodule inside the cyst due to a mixture of hair and sebaceous material. There is no blood flow inside the nodule, and it is usually associated with a distal hypoechoic area known as acoustic shadow. Here you can see the hyperechogenic dermoid plug inside the cyst, and this hypoechoic area is the acoustic shadow. Sometimes the acoustic shadow is large and obscuring part of the dermoid plug. In this case, we can see exactly where are the boundaries of the dermoid plug. Here you can see part of the dermoid plug on top of a large hypoechoic area. This is known as tip of iceberg sign. Another feature is dermoid mesh. It is hyperechoic linear and punctate echoes inside the dermoid cyst, which correspond to hair strands. Here you can see these hyperechoic lines and dots inside the dermoid cyst. A rare but characteristic feature of dermoid cyst is known as floating fat globules. Regarding management of ovarian cysts, ovarian cystectomy is suggested. This will provide definitive diagnosis, preserve ovarian tissue, and avoid complications such as torsion, rupture, or malignant changes. In women who have completed their families, salpingo-oophorectomy is an acceptable option. What is the role of expectant management of dermoid cyst? Ho et al. Examined the role of expectant management of ovarian dermoid cyst. They examined 289 women with ovarian dermoid cyst. 93 women were managed expectantly. During follow-up, 24 women required surgical intervention due to symptoms or complications, while 69 women had successful expectant management. And finally, they concluded the success rate of expectant management of a dermoid cyst is high, and this approach should be considered as a viable alternative to surgical management.